Good evening. While everything gets loaded up here. My plan tonight, just some housekeeping for the next couple days. We'll get out early tonight for the snow. All right, it's supposed to start, and it's actually supposed to get cruddy early. So we'll get everybody. You all right there, Steve?
Yeah.
You want to start bobbing your head back and forth?
Well, remember how I said that I had my 3 after my surgery?
Oh, is that why?
And I might miss class tonight?
Oh. Understood. All right, so you got the whole Brian Bosworth thing going on.
It's a tad bright right now.
There we go. Oh, you're taking them off. Well, as I'm making a mockery of you. All right. So tonight we're going to do some carbon monoxide cyanide stuff. Tomorrow night we are meds. And so if you haven't done your medications and all the information that I had very clearly told you that you need to know, please have them done for tomorrow night because we'll review. I'm not going to give you the information because if you were smart and if you were me 20 years ago, I'd say, well, if he's going to give all the information to us, then I'll just wait and do it tomorrow. But I won't. I'll be asking you questions specifically on just some things and give you little pearls of wisdom on each of the medications just from experience that you may not read in the textbook or read in a drug guide or anything available in any of the resources I gave you. Exam 1 for Med Emergencies 1 will be Monday, a week from tonight. All right, and it's actually all things respiratory. So what we're going to do, start tomorrow night. We're starting cardiology tomorrow night. No cardiology will be on the test. However, it just didn't segue nicely because a portion of our class is off this week. And it would be unfair to do the test in 2 different sections. So we'll do it all next Monday, right at 6 o'clock. The quiz, it's kind of funny. And I try different scenarios and I try different strategies in doing these things. And I kind of thought all along that the whole quiz correction thing was good. And a lot of people had given me some positive feedback from that. Well, it's good. It's a really good learning tool because I see, where I went wrong. And I have to actually dig and find out, why I was wrong and blah, blah, blah. And then I devised this, what I thought to be evil little quiz. And not only is every right answer right specifically for a reason, but every wrong answer is wrong, not because it's wrong because I just made it up, but every wrong answer I tried to make poignant and related to the question to make you think. And what I saw was 2 attempts. One attempt was very poor, and one attempt was very good. Because what happens, because again, I was a student once too, and actually I still am going for my master's, so I'm not unlike you, trying to find the easy way around things. You take the quiz the first time, and it gives you your answers, and it gives you the right answers. And you're smart, none of you are stupid, and you write down the right answers, and you take the thing again, and you all get 24s and 25s. 24 to 25, 25. So, we'll see. All right. That was as I said, that was a quiz that actually took me like 3 hours to write. So everything was there that needed to be. And I would say that if you did 15 or 16 out of 25 on your first attempt, study. All right. Again, quizzes are meant to just kind of show you where you are, and they're not very heavy. We'll do 5 or 6 quizzes in a semester, and collectively they're only worth 20%. So one quiz is 4% of your grade. It's relatively inconsequential, with the exception that it can bring you, from a high B to a low A, or from a high C to a low B, or, it can help in that regard. Tests and the final, however, are actually inordinately heavy. The 2 tests are 25% apiece, and the final is 30%. All right, so They weigh pretty heavily, and your performance on the quiz is usually pretty commensurate with how you're going to perform on a test. So if you got a 15 in the first attempt, read. All right, go back over it and see where you went wrong, and if you didn't know an answer and you guessed, well then figure out what if you didn't know what polycythemia was, look it up. Know it, because you may see it again, and everything on there you'll see again. As far as the test goes, there are no specific references to medication dosages, and there's no specific references to intricate nuances specific to individual medications. All right, it's all very global application, and if you did legitimately do well on my quiz, then I think you'll probably do fairly well on the exam, just all by yourself. If not, you got a week. And then cardiology will be much the same thing. What else did I want to say? Something else. I don't know. I do reserve the right, however, to, quiz you at any time on medication knowledge. So, have that there. And that will become a fairly regular lab component. You see kind of where I've been going with how lab's been going. I want that to continue. And, at some point I'll be less forgiving on, well, what's the dose for blah? You gotta know it, all right? You gotta just know it right up. So that's that. So tonight's CO and cyanide, some stuff, and we'll get out of here. I'm around if anybody wants to stick around. I apologize for not getting back to you. I did not have any time this afternoon. I was on around noon, and I didn't see anything. I had to do some grading. Midterms are in. For the most part, everybody. I had to do a midterm. I had like a quiz to base it on. So don't put too much credence in the midterm grades if you see them, if you go into Wired and look for such things. However, if you were specifically identified and I popped you in for an early warning, you'll get notification from that, and we'll chat. So I just want to make sure that everybody is up to speed and kind of where they are versus where they need to be. So I'll be around. I'll probably be here till 10, 11 tonight, just doing stuff. So if anybody wants to stick around, feel free. Anything for me? No? Questions on the quiz while it's still fresh in your minds? Malta, nothing? Okay, all right. Well, I have this video, which is excellent. There's a guy in Clifton Park who's a paramedic. His name's Mike McAvoy. He's actually the EMS director for Saratoga County. Probably the smartest man I've ever met on a variety of levels. And he's been a mentor of mine since I was a wee little EMT. And, as smart as I think I am, he continues to get smarter, which makes me feel stupider. So. But he is one of the national researchers and national authorities on the effects of CO and CN poisoning, and lectures at the NFPA, and actually has written policy at the federal level for the NFPA as it pertains to fire rehab and CO exposure and stuff. So for any of you that are quasi-interested in fire rehab, this is excellent. And so this video, on top of the presentation that I stole from him, will be the topic for tonight. So hold on, stand by while I do this and this. Make sure the audio works, because I have to do this, I think. Oh yeah, okay.
Smoke inhalation is a complicated and serious illness from which many people die, but oftentimes it's dismissed as just smoke inhalation. We have to change our attitude and look at the issue with new eyes. And if we can do that, we can start saving lives.
Sometimes we make decisions that are based on what I think is old medicine.
It really makes you wonder if we may be changing the landscape not only for cyanide exposure, but also for carbon monoxide exposures.
I think it's incumbent upon every American firefighter to understand the toxicity of smoke, and not only to understand it for their own safety, but for their family safety, for the people we swore to protect.
Hi, I'm Rob Schnepp. Smoke is everywhere, and the fire service knows it. You know it. It's also well known that smoke kills more people than flames. Often, carbon monoxide gets all the credit when we think about the dangers of smoke exposure. Rarely acknowledged is hydrogen cyanide, which is created during the combustion process of burning laminates, synthetics, foams, plastics, and even wood. Nearly everything in our homes and offices today. And when smoke inhalation victims are exposed to both toxicants, their medical conditions become much more complicated. In short, hydrogen cyanide and carbon monoxide are deadly together. This is why we call them the toxic twins. Up until now, the vast majority of firefighters would equate the worst cases or releases of carbon monoxide and hydrogen cyanide with hazmat incidents, or chemical warfare, or an industrial accident, or some other sort of dangerous situation. And you know that if dispatched to any one of these incidents where carbon monoxide or hydrogen cyanide was identified or suspected, your approach would change. Your tactics would change. And most importantly, your perception of the hazard would change. And that's the key. As you sit there today watching this video, be prepared to change your perception of fire smoke. The reality is that hydrogen cyanide is present on some level on the scene of every fire we run. This includes structural fires, vehicle fires, dumpster fires, and while you might not think so, wildland fires, especially the wildland-urban interface when homes and buildings are burning. When a firefighter or civilian breathes smoke and requires medical attention, they become a smoke inhalation patient. Between 1997 and 2006, over 182,000 people in the United States were diagnosed with smoke inhalation, and more than 30,000 of those people died from that illness.
We've spent probably 20 years of collecting data, and looking back at that time, we've had virtually no civilians come out of a structure fire or a smoke exposure in cardiac arrest who we've been able to resuscitate. And in fact, I think most EMS providers around the country probably have a similar experience. The ability to bring back somebody who's gone into cardiac arrest from smoke or from exposure in a fire is virtually nil.
So you might be asking yourself, what is smoke inhalation? Well, the basic definition is the breathing in of harmful gases, vapors, and particulate matter contained in smoke. I know it's a somewhat nebulous definition, but suffice it to say that smoke inhalation is definitely an illness.
We look at the number of people that are smoke inhalation victims a year that die. How many of those would really have died, and how many of them would have been viable if we used an antidote like hydroxycobalamin on the patients? Maybe we would consider a lot more people viable than we do now.
So this program will teach you to better understand and treat that illness. Here's a few important things you'll learn. First of all, you'll be aware of the destructive physiological processes of hydrogen cyanide and carbon monoxide, and really importantly, that hydrogen cyanide is present on every fire ground at some level. You'll also learn how to assess smoke inhalation at the basic life support level, or BLS, and the advanced life support level, or ALS. And lastly, you'll learn how to administer aid to the smoke inhalation victim and treat that exposure. So, before any of this will make sense, as a first responder, you have to accept the fact that hydrogen cyanide could be present at any fire and must be considered when treating a smoke inhalation patient. There are numerous toxicants within fire smoke, but there are two that challenge the pre-hospital care provider when it comes to assessment and could potentially complicate any treatment rendered. Remember this: hydrogen cyanide and carbon monoxide are the toxic twins. So let's take a moment to understand the physiological process of hydrogen cyanide and carbon monoxide. Normally, oxygen is transported from our lungs to the rest of the body within red blood cells inside structures called hemoglobin. These act like little seats on a bus, carrying passengers to a particular destination. The oxygen molecules leave the red blood cells and are delivered to the body cells, which then use oxygen to generate energy. This allows, among many other body functions, a normally beating heart and an intact neurological system. Simply stated, carbon monoxide replaces much of the oxygen being carried by the red blood cells by taking up most of the seats, which reduces the amount of oxygen reaching the cells throughout the body. Less oxygen delivered to the cells means less energy production and impaired organ functions, including challenges to our cardiovascular and neurological systems. Carbon monoxide's toxic twin, hydrogen cyanide, acts within the cells to disable the cell's ability to use what little oxygen is reaching them. This may result in a buildup of lactic acid. Hydrogen cyanide is a principal cause of incapacity or death because it is driven directly to the heart and brain. These organs in particular rely on a substantial supply of oxygen and therefore experience the most immediate insult. If you breathe smoke containing hydrogen cyanide and carbon monoxide, this is what's happening in your body. So keep in mind that large exposures can result in severe symptoms within minutes and even death. And even if you have never gone down from a smoke exposure, you've certainly been exposed to sublethal levels. And who knows now what your heart or brain looks like. Hydrogen cyanide kills the organs and carbon monoxide is the thing that kills the blood. Both these things, in conjunction with each other, create a challenging situation for any pre-hospital care provider. Now that you've seen the destructive capabilities of hydrogen cyanide and carbon monoxide within the body, it's important for you to accept that these toxicants are on the scene at your fire ground. And while this program is not about detecting hydrogen cyanide in fire smoke, we thought it might be wise to show you that the threat of hydrogen cyanide exists in virtually every fire you go to.
And so they'll call me up and say, oh, we got another kit we want to try. Yeah, we need some cyanide poisoned people. And so usually I just call one of the union halls and say, you know, you guys have a fire on the last day. And they're like, yeah. I said, all right, I need 5 guys who are at the fire. Bring them down, test them. They always have cyanide in their blood. You know, any firefighter's been in a fire. They always have some.
Hydrogen cyanide is generated during the combustion of all kinds of household and workplace items. Items like sofas, cabinets, desks, drapes, blankets, and carpets. Hydrogen cyanide is not immediately identifiable by the smoke. Not by its color or its amount. Hydrogen cyanide is invisible and only detected through metering and monitoring. Here are some important values to think about. The immediately dangerous life and health value, IDLH, for hydrogen cyanide is 50 parts per million. As you can see, NIOSH's recommended exposure limit is 4.7 parts per million. OSHA's permissible exposure limit is 10 parts per million. And the Environmental Protection Agency's acute exposure guideline level, where life-threatening effects or death will occur, are 27 parts per million for 10 minutes, or 21 parts per million for 30 minutes. Let me share with you a few real-world examples. Here's a pan on the stove, moderate smoke, 22 parts per million of hydrogen cyanide. A dumpster fire, 25 parts per million of hydrogen cyanide. This is a bigger example, a warehouse fire. 26 parts per million detected around the exterior, not in the active fire, but at the exterior of the building. Think about where your command post might be placed in a scene like this. Small fire in an apartment complex had nothing more than smoldering cabinets, pot on the stove, very little fire damage, generated 30 parts per million. This slide shows a reading from a training exercise, 48 parts per million of cyanide. What's interesting about this is the reading was taken at the backside of a burn building with only hay used as a fuel for the training fires. These meter readings that you see are taken by firefighters, your colleagues. They're not doctors, they're not scientists, they're not researchers doing work during controlled fires in a laboratory setting. Are you surprised? You shouldn't be. Hydrogen cyanide is your new invisible enemy. Accept that. When we put on our hat of pre-hospital care provider, we need to be conscious that the inhalation victim is exposed to the incipient stage of the fire. This is the combustion process when hydrogen cyanide is the most prevalent.
People have asked recently about the Underwriters Labs study, the smoke characterization study, which essentially told us that cyanide was not found in the active fire phase of fires, and raising a question of, if we're not finding it in the fire itself, how is it getting into a patient, and is it really in the patient? What Underwriters Labs was doing in that study was measuring the characteristics of smoke from live fire, and there certainly is a whole lot of period before and after a fire that was not included in that study. In the pyrolysis stage, in the incipient stage of a fire, when things are starting to burn before you see flame, they off-gas tremendous amounts of all kinds of things, cyanide being one of the major things that is present. And in situations where there's been a high quantity of those sort of combustibles, we found tremendous amounts of cyanide in the victims at the fire. So the Rhode Island nightclub fire had huge quantities of cyanide in the victims of that fire because there were components in the smoke during the initial incipient or the pyrolysis stage of that fire that poisoned those people.
While firefighters are wearing PPE, specifically in SCBA, now that's providing you're wearing it and using it, the civilians aren't. They are exposed to the highest levels of hydrogen cyanide from the very moment the combustion process begins. And wildland firefighters are not exempt from hydrogen cyanide exposure, most especially in the wildland urban interface environment when homes and buildings are burning. And quite frankly, the wildland community could be at a greater risk because they typically don't wear SCBA. And even though structural firefighters have the benefits of SCBA, not using that air, by choice or by circumstance, like an out-of-air situation, puts you at risk. This also includes incident commanders, or those firefighters operating outside the building, who might even be out of the range of visible smoke, but certainly could be exposed to near IDLH levels of hydrogen cyanide and not even know it. This is what we've learned so far. Hydrogen cyanide kills the organs by disabling the cell's ability to use oxygen in the generation of energy. Carbon monoxide kills the blood by disabling its ability to transport oxygen to the organs. And I think we've shown, beyond a doubt, that these two toxicants are on the scene of every fire you run. Now you see the problem. But it's important to realize that out of all the dangerous components in smoke, hydrogen cyanide is a toxicant whose health effects can be reversed by an antidote. An ideal antidote is not harmful to patients with concurrent carbon monoxide poisoning and will be quick, safe, and easy to administer. Currently, there are two antidotes available for hydrogen cyanide poisoning. One, called hydroxycobalamin, is currently marketed in the United States as Cyanokit. The cyanide antidote kit, which we will call from this point CAK, is also known as the Lilly Kit, Pasadena Kit, and the Keystone Kit. But for the most up-to-date information on how and by what name these drugs are being marketed, please visit firesmoke.org. Using the CAK in its entirety is actually contraindicated in the face of smoke inhalation because it contains nitrites, which decrease the oxygen carrying capacity of the red blood cells. That means it fails as an ideal antidote for smoke inhalation patients because victims of carbon monoxide poisoning already have a decreased oxygen carrying capacity. Keep in mind, the CAK also contains sodium thiosulfate, which can in fact be administered to smoke inhalation patients. But don't worry, in an attempt to clarify what these drugs do once administered, we will take you back inside the body to explain how the drugs interact with the toxic twins. This information is very important, and before we go any further in the program, I need to drive this point home. It's in your best interest, and in the best interest of the patients you are treating, to educate your local medical community in order to prevent the administration of the entire CAK to smoke inhalation victims on the scene or at the hospital. So based on that, Let's first see what happens when the entire CAK is used. As we discussed earlier, during normal body function, red blood cells transport oxygen from the lungs to the rest of the body within the little seats called hemoglobin. When certain drugs of the CAK are administered, most notably the sodium nitrite and the amyl nitrites, they promote the formation of a different kind of seat within the red blood cell. This seat absorbs hydrogen cyanide instead of oxygen. And when the red blood cells absorb hydrogen cyanide instead of oxygen, there is less hydrogen cyanide reaching and attacking the body cells and interrupting energy production. Also, these new seats within the red blood cells act like magnets to the hydrogen cyanide within the cells, removing the hydrogen cyanide and allowing energy production to resume as long as the cells are receiving oxygen. But the problem is, at its most basic level, the cells are not receiving oxygen because now that the red blood cells are transporting hydrogen cyanide, there are way fewer seats for oxygen to make the journey from the lungs to the rest of the body cells and create energy. Also, in the presence of carbon monoxide, which, as we learned earlier, also takes up seats within the red blood cells, way before oxygen can, there is even far less oxygen being delivered to the body cells. So think of it this way. Even though we're pulling hydrogen cyanide out of the cells, which you would think would be the right thing because it allows energy production to resume, not enough oxygen reaches the cells to fuel this process. And really it all boils down to this. Oxygen needs to do its job. Another thing to keep in mind is that sodium nitrite and amyl nitrite are vasodilators, which lowers the blood pressure. And this is bad because victims of hydrogen cyanide poisoning already have low blood pressure, making sodium nitrite a dangerous drug in the setting of smoke inhalation. Sodium thiosulfate is the third component of the CAK and is the only drug safe to give to smoke inhalation victims. Within liver cells, sodium thiosulfate combines with hydrogen cyanide to form thiocyanate, a far less toxic version of hydrogen cyanide that can be excreted in the urine.
Well, the kit that we used before for cyanide exposure is really designed for when you're exposed to cyanide. And if that's all you're exposed to, then all the things that are in there are beneficial. But when you've got a mixed gas exposure mixed with carbon monoxide, and you use all the components in there, well, you know that the carbon monoxide binds the hemoglobin, and it has 200 times greater affinity for the hemoglobin, and so the oxygen can't get on it. Well, some of the components of the other kit will also bind to hemoglobin, and you develop a condition called methemoglobinemia. And in the end, what you've done is you've taken even more hemoglobin, you've neutralized more hemoglobin, and so there's even less oxygen carrying capacity in the blood. Really, the only component that is helpful is the sodium thiosulfate. The other ones will actually make the situation worse. And the sodium thiosulfate by itself is helpful, but I don't think it's as good as what we can get with the hydroxycobalamin. And so between the two, that's why the Houston Fire Department, we went to the hydroxycobalamin.
In the face of severe smoke inhalation, hydroxycobalamin is the antidote to consider as treatment in hydrogen cyanide poisoning, as it can be safely given to a smoke inhalation victim with concurrent carbon monoxide exposure. Simply stated, hydroxycobalamin binds to hydrogen cyanide to form vitamin B12, which is harmlessly excreted in the urine. The good news is hydroxycobalamin has a very simple mechanism of action. With less hydrogen cyanide in the body, cells are able to process oxygen and create the energy it needs to keep the organs working. Remember, this is all about letting oxygen do its job. Sounds simple, doesn't it? Actually, it is. Hydroxycobalamin has no known adverse effects on the oxygen-carrying capacity of the red blood cells and does not decrease blood pressure. Both of these are potentially significant benefits when treating victims of smoke inhalation. Hydroxycobalamin may interfere with the accuracy of some laboratory values, and depending on local protocol, blood may be drawn for cardiac enzymes, serum lactate, and basic chemistries prior to the administration of the medication. However, blood collection should not delay medication administration in any circumstance. Because of the color of the drug, it results in a red discoloration of the skin of the patient and red-colored urine for up to a week. There are no contraindications for administering hydroxycobalamin in the field. This is a very important point. Once again, let's review. Hydrogen cyanide kills the organs, carbon monoxide kills the blood. These toxicants are on the scene of everyday fires, and now you know that hydroxycobalamin is a safe drug for smoke inhalation victims in the face of hydrogen cyanide and carbon monoxide exposure. We can now discuss how you can assess smoke inhalation victims to determine if antidotal therapy is indicated. As toxic twins, hydrogen cyanide and carbon monoxide share similar effects, and it can be hard to differentiate between the two. Identification of carbon monoxide poisoning can be achieved with a carbon monoxide oximeter, if it's available. But there is no definitive field test for hydrogen cyanide poisoning, and this is a problem. However, there are signs and symptoms that first responders should look for in the limited window of the pre-hospital environment to determine if drug treatment is necessary.
If we were to wait until we got a cyanide test back, we'd be waiting several days, if not 7 to 10 days in actuality. And I think that's the experience in most places in the United States. There are a very limited number of labs that are actually on the list of laboratories that the CDC says are okay to run cyanide tests. And so for us to get that actual lab value back would be long after we sent the blood to the laboratory. So the presumptive diagnosis, and it has to be presumptive, is based on signs and symptoms in the patient.
Once a smoke inhalation victim has been rescued, he or she must quickly be removed to a safe area away from the smoke intoxicants for further assessment and treatment. If you can answer yes to all three of the following questions, treatment for hydrogen cyanide exposure should be initiated in the pre-hospital environment. First of all, was the victim removed from a closed space structure fire? Second, is soot present around the nose and mouth? And last, does the patient present with an altered level of consciousness or some other abnormality in their mental status, such as giddiness or the inability to answer questions appropriately? These three indicators are present, there's a significant chance that the victim is suffering from acute hydrogen cyanide poisoning, and pre-hospital treatment should be administered immediately.
Here in the Houston Fire Department, if we pull someone out of a fire, whether it be a civilian or a firefighter, it doesn't matter, and they have been in a confined space and they've got smoke inhalation and they have altered mental status, that's really all we're looking for, is altered mental status, because at that point you have to make the assumption that the cyanide has gotten in and is interfering with oxygen delivery to the brain, and that's why they're altered. And if that's, so really that's the criteria, and we will then start the hydroxycobalamin therapy.
Other indicators include low blood pressure, called hypotension, shock, nausea, vomiting, convulsions, possibly a pinkish to cherry red complexion caused by the abnormal high oxygenation of venous blood, and in some instances, the victim's breath may have an almond-like odor attributed to the excretion of small amounts of hydrogen cyanide in the breath, although in the setting of a fire, this may be very difficult to detect.
Our thought process now is that when you have an individual who's exposed to smoke or products of combustion in some way, shape, or form, that individual should be thought to have cyanide poisoning if you can't explain by any other reason some hemodynamic disorders like hypotension, altered level of consciousness, seizures, acidosis that doesn't resolve from other kinds of treatment.
If a firefighter were to require treatment for whatever reason, the same indicators apply, and most especially in an out-of-air situation. If a firefighter is the smoke inhalation victim, ask yourself one additional question. Was the firefighter using, not just wearing, but using air at the time of the exposure? Cyanide is also much more difficult to recognize in firefighters unless the exposure is acute, because for the most part, they aren't honest with themselves if they don't feel right and don't want to let anybody know. Two primary indicators first responders can look for in their brother and sister firefighter are severe lethargy or giddiness. Again, this is difficult to recognize because firefighting is very strenuous. Acute exposures, it won't be hard to recognize the symptoms, which include low blood pressure, shock, nausea and vomiting, and convulsion. And if the victim, whether a civilian or firefighter or other public safety responder, is unconscious or in cardiac arrest, you've got a good candidate for antidotal therapy.
The following information is a general overview of smoke inhalation treatment and is not to be used as a specific medical algorithm for aid.
Before discussing the suggested BLS and ALS treatment protocols for smoke inhalation, we should probably talk about a few basics. Remember that smoke and products of combustion will cause poisoning and direct irritation of the airway and lungs. And any injury of this type to the airway or lungs will definitely cause an impaired ability to oxygenate and ventilate. Any pre-hospital treatment for smoke inhalation must include the administration of oxygen. Once the victim has been rescued from the environment and becomes a patient, always move that patient to a safe area far away from the smoke intoxicants for further medical assessment and treatment. Quick field decontamination is recommended. This includes removal of the patient's clothing and a quick wash with water if time permits. You can think of this in the same terms of how you would manage a basic trauma patient. You perform a quick strip and flip prior to transport to the hospital. What this does is it protects all of the caregivers down the line from secondary exposure to the off-gassing of the byproducts of combustion that might be trapped in or on the patient's clothing or skin.
Basic life support includes establishing an airway, ensuring the patient is breathing, ensuring the patient has blood circulation, and administering high-flow oxygen. Evaluate and treat any burns and/or trauma, and consider spine immobilization if indicated. Remove the patient's clothing, and, if appropriate, do field decontamination.
If the patient is responding positively to basic life support, antidotal therapy may not be required. However, rapid transport to the appropriate receiving hospital is indicated.
Advanced life support includes establishing IV or IO lines, treatment of underlying conditions including cardiac arrest, respiratory distress or arrest, and seizures. Assess the patient for hydrogen cyanide poisoning as discussed earlier, and treat with antidotal therapy if indicated. Transport the patient to the appropriate receiving hospital.
The suspicion of acute hydrogen cyanide poisoning should prompt the pre-hospital provider to consider antidotal therapy based on local protocol. Carbon monoxide and hydrogen cyanide toxicity associated with cardiac arrest, secondary to smoke inhalation, may be treated with hydroxycobalamin. Refer to the package insert or your local protocols for hydroxycobalamin dosing information.
So one of my philosophies is the key to this whole thing is to get the ball rolling in the pre-hospital setting. Clearly, the sooner we get started, the better. In a couple of the cases, we saw them develop neurologic symptoms, some recovery of neurologic function halfway through the first bottle. And as you know, for an adult, it comes in 2 bottles, and it's a 2-bottle administration. But halfway through the first bottle, they started moving. And so what that tells me is that it is very rapidly acting, at least in getting to the point where the brain can start to function again. And man, I'll tell you what, if my firefighter or my family member, I want that happening as soon as possible. So we're going to get it started in the field. But the number one most important reason is that's patient care oriented. We've used a fairly large number of times here, more so, quite honestly, than I had anticipated. A fire where the second-in company went in to fight the fire. There was a flashover. When that occurred, a captain somehow got away from the pack, and as soon as they came out, they recognized he was missing. They immediately went back in. They found him in the room adjacent to where the flashover had occurred. No helmet, no face mask. They dragged him out. Again, it's difficult getting folks out when you can't see what's going on. They got him out. We got him on the heart monitor while we were doing CPR, and he was confirmed to be in asystole. No heart activity at all. Similar story. CPR, oxygen, intubation, epinephrine, gave the ACLS drugs, and added the hydroxycobalamin. Again, a very rough, rocky, prolonged road in the hospital. He has pretty significant burns to his face and to his hands, not surprisingly. But he is back to work, 100% neurologically intact. He's a father, he's a husband, he's a firefighter. Tragically, one early New Year's morning, there was a fire in a home with 3 little girls. Ages range from 6 to 12, I believe. One of the girls came out, was awake, coughing, had smoke inhalation, but was awake. The other two sisters came out, one with agonal respirations, the other one not breathing at all. Both got CPR. They both got the cyanocobalamin or hydroxycobalamin kit, and again, a very long course in the hospital with the burns, and they went through all kinds of complications, metabolic complications, but in the end, they're back at school as a family unit. All 3 little girls are together again.
At the end of the day, you need to know that smoke inhalation is a complicated illness. And clearly, not everyone exposed to fire smoke warrants aggressive treatment, and it's up to you, the first responder and fire professional, to make informed decisions in the field. Both the prompt recognition of acute hydrogen cyanide poisoning and the immediate initiation of care are necessary for effective treatment. You, the fire professional, are often the first line of defense and the first person to provide medical care for victims of smoke-associated hydrogen cyanide poisoning in the pre-hospital care setting. This is what you do. And by recognizing hydrogen cyanide poisoning and effectively initiating corrective measures according to protocol, the fire professionals can save lives. You can save lives. However, keep in mind, all that we've talked about, all the antidotes we've discussed, they're not miracle drugs. And success is based on giving the right drug to the right patient at the right time.
It's not 100%. We've had other cases where we've had folks where we pulled out of fires and altered mental status and still had a pulse, and we've given the hydroxycobalamin, and some of them we got pulses back on, and some we didn't. In one case, we had a lady we brought out and got her pulse going again, and she got the hydroxycobalamin, and it turned out that in the end she had many complicated medical problems, and the family decided to withdraw care. But the thing is of note for her is that our local hyperbaric chamber and burn center, where we bring all of our burn and smoke inhalation victims, she is the woman who now holds the record for having the highest carbon monoxide level of anybody with a pulse. And so we wonder if that isn't the case because she got basically the cyanide antidote. So in the past, all folks who had had that much carbon monoxide from the smoke also had so much cyanide that they didn't survive to the hospital. And in this case, while we couldn't completely reverse all the effects of her carbon monoxide, we at least were able to neutralize the cyanide such that her tolerance for carbon monoxide was greater than what it would have been otherwise. And as I said, tragically, in the end, the family decided to withdraw care, and they know better than I do, so they made the right decision. But it really makes you wonder if we may be changing the landscape, not only for cyanide exposure, but also for carbon monoxide exposures.
Strange as it may seem, there is also a common misperception that as patients move through the continuum of care, meaning from the pre-hospital environment to the emergency department to the ICU, they will receive a higher level of care when it comes to treating smoke inhalation. Unfortunately, that's not necessarily the case. It could be up to you, the pre-hospital care provider, to act as the patient's advocate as they enter into the system.
The other logistic reality of it is that the hospitals sometimes are a little behind the curve from EMS with some things, and this appears to be the case here. So if we can get the antidote started in the field, when it gets to the hospital, we know that they may ask, what is this? And I'll tell you what, the other thing is when you reconstitute it and it starts going, it's a bright purple red color, and it really gets people's attention, like, are you giving blood in the field now? So, no, this is, and we explain to them what it is. Here in Houston, most of the hospitals that we, there's only a couple of hospitals that we would bring somebody that's critical to. Well, their staff today, they're familiar with it, but they're familiar with it because we introduced them to it on actual cases. Even though we had told them ahead of time, their hospitals are big institutions, and it's sometimes hard to get the information to filter down to the doctor and the nurse that are going to be there at 3 a.m. on Saturday when you bring the case in. And so we get started in the field. It's the best thing to do for the patient. The other thing is it ensures that the patient's going to get the therapy. If the hospital doesn't know what it is, we teach them right there. They've always got a doctor or the fire department who they can call. We'll explain to them over the phone what they want. But our paramedic supervisors are very
Let me offer you another perspective. Think about your fire department and what you were doing with rapid intervention 10 years ago. I venture to guess that most people watching this video were not doing anything with rapid intervention training at that time. Since then, we've paid a lot of attention, we've spent a lot of time, and we've spent a lot of money on rapid intervention training. But let me ask you this. Without a smoke inhalation treatment protocol, can you really complete the save? So here's a take-home message for you. Firefighters, you, will continue to be exposed, and civilians will continue to die until we implement appropriate medical treatment for smoke inhalation. Again, the drugs that we talk about, the antidotes we talk about, they're not miracle drugs. But keep in mind, it's the right drug for the right patient at the right time.
You know, when I think about this, and I think, why wouldn't the department go this way? And you know, here in Houston, maybe we've been the oddball case, but you know, in the first several months of having it, we saved 2 children and 2 firefighters. And these are people who are essentially dead when we pulled them out of these buildings, and they're alive today. And so we'll never go back. And so I would really ask folks, you know, why aren't you doing this? We lose way too many firefighters every year. We lose way too many civilians to fire-related deaths. And some of those, there's not anything we're going to be able to do about it. They were just in the fire too long, and there's nothing that anybody can do. But some of those folks are in that area where if we get them out and we manage them properly, they'll get back like our 2 firefighters, and they'll go back to school with their sisters, like the 2 little children we have. These are real cases. It really happens. It has really worked. You need to really consider it.
Really.
I hope this program helps you to be a more informed firefighter and a safer firefighter, because safer firefighters make for safer communities.
All right. Now, the interesting thing from a end user perspective on cyanocobalamin, which we'll talk about in a little bit, the cyano kit is the trade name for this drug, which is only marketed by people that make the cyano kit. But it's a derivative of vitamin B12. It's thiamine. All right, and we've been given thiamine for forever. In smaller doses to combat alcohol-induced seizures, or what we call the delirium tremens, for people that are going through alcohol withdrawal and can have some not seizure activity, but convulsions related to alcohol withdrawal. And thiamine was the antidote for that. Way back in the day, we used to have what we called the coma cocktail, and it was Narcan for opiate overdoses, thiamine in case you were unconscious from alcohol withdrawal, and D50 or dextrose 50% in case you were low on blood sugar. That's before we could even test in the field for glucometry. And then we got these stupid little strips like you dip in your pool and check your pH in your pool, and you have to dip some venous blood on it and leave it on the bench seat and go back to it a couple minutes later and wipe the blood off, and whatever color the little strip was, you compared it against the side of the container like you're checking your pool chlorine, and you got a basic idea of what the blood sugar was. So way back we didn't have any idea, but and then kind of the post, not even post 9/11, but kind of post the first World Trade Center debacle in '93, they paid some attention to weapons of mass destruction and specifically like toxic gases, and because there were some threats, and we had become a bit more, it seemed, aware of the potential terrorist threats of toxic gases and whatnot, and cyanide became a big one, and they put out those Mark I kits, which was atropine and proloxidine or 2-PM chloride or all of that, and the state through a grant and whatnot had issued these kits. They're auto injectors that we all had to carry on our ambulances or in our first response units that were atropine, or a double-ended auto injector with 2 different drugs in it, and you jammed it in the side of your leg, and it was supposed to combat the effects of cyanide poisoning in first responders or anybody that we would encounter. And that included actually the organophosphate poisoning for the sludge algorithm: salivation, lacrimation, urination, defecation, gastroenteritis or gastrointestinal distress, and emesis. So all these hyperacetylcholine states from organophosphates plus cyanide, in case we didn't know. But the joke, again, joke on the ground pounders was, if we ever found anybody that was down from all these things, we just take the whole kit and start jamming them in our own legs as we ran away. Run away from the cloud and jam as many of these things in your leg as you can, and you might live. So fortunately, they've all since expired, and we found a home for them in the top drawer of the supply closet where they will collect dust and never to be used. But when hydroxycobalamin came out, and we said, wow, it's just mega doses of vitamin B12, but B12 binds with cyanide, and you pee it out, which is kind of cool. The only problem is it's $800 a dose, and it has not come down, and it is still a proprietary drug, and it's beyond the limits of many agencies' ability to purchase. I mean, from a reimbursement standpoint, the drug costs more than the transport. You can recover from billing for the transport. So a lot of communities kind of rely on, well, the hospitals have it, so we'll get it to the hospital. We'll get it from the hospitals. The problem is, in my county, we have a small county. It's one of the smallest in the state, and we've got one hospital that's centrally located in the county, and a lot of outlying rural area. Go out, towards Schoharie, it's very rural, and you go up north towards Saratoga and out toward Montgomery, it's very rural. And in order for this drug to be effective, it needs to be administered within the first 10 minutes or so, and the transport times aren't there. It needs to be done, at the fire scene, and as part of the initial resuscitation, in order for it to become effective and to not, seeing kind of vaguely how they, the little graphic of how cyanide binds and how CO binds, you need to do it quickly, before the effects of the drug take hold, and we can bind to it and get it out, and we can actually maybe reverse these things. If you're fighting a fire in an urban environment and the hospital's around the corner, well, that's one thing. But if you're 20 minutes out, you need to get this drug on board. So fortunately, a lot of counties, specifically in New York, have a county-wide protocol where they've acknowledged the fact that it may be unrealistic for every agency to carry a cache of this medication. Because if you have one, you need two, because just what happens if you break one or whatever. So the $1,600 of a net investment with a 2-year shelf life, and with the hopes that you're never going to need it. And it makes most managers very, very angry when they throw away $1,600 worth of medications every 2 years. So what they've done is they've deployed them strategically throughout the county and done like auto dispatch protocols, where if there's a fire and there's any occupants of the fire, the agency that carries the quarter of the county or the third of the county or whatever that you've developed, that zone's cyano kit gets automatically dispatched. So it's there, it's available. There are some protocols, and we'll take a look at one of them when we get back and kind of show you how it works. And there's a little video on how the drug is mixed. It comes in 2 bottles. You put them together, you drip it in, and you kind of piggyback it into your line. I'll have to dig that off of YouTube. There's a pretty good video there. And then we'll take a look at the different protocols and how this works. But and again, this was, if you couldn't tell, produced by the people that make the drug, or paid for by the drug, produced by somebody else, but certainly funded by the drug company that makes this drug. So what? It works, and it's not like they're trying to, they're unabashedly promoting themselves. The science is there. This thing works. So let's get the word out. And that's a good thing. But, they're trying to get you to use it for people that have an altered mental state, post-fire exposure, where most of the protocols are fairly more restrictive, and it's usually, arrest is imminent, or the patient is profoundly hypotensive, or there's some fairly significant characteristics that paints this patient as critical, or at least unstable upon your assessment, which would then drive administration of this more aggressive procedure, versus somebody who is presenting somewhat normal, and you're going to manage them in a more traditional sense. So it's a bit more consideration to worry about than just unabashedly giving this stuff out like albuterol. It would make your supply people cringe, have a bit of seizure of their own. But all right, we'll look at that after when we take 10, and we'll come back. Let me dig out some resources here during the break.
Goes into effect on certain kinds of weapons and high-capacity magazines. She's asking if a ban goes into effect on certain kinds of weapons and high-capacity magazines.
And what's your name?
Kate.
Kate, if you want to protect yourself, get a double-barrel shotgun, have the shells, a 12-gauge shotgun, and I promise you, as I told my wife, we live in an area that's wooded and somewhat secluded. I said, Jill, if there's ever a problem, just walk out on the balcony here or walk out, put that double-barrel shotgun and fire 2 blasts.
You'll be completely fine.
Oh my God.
Ow, Alan!
What's wrong, Autumn?
Pull the trigger. Jesus.
Ow, it hurts. I don't like it.
I promise you, whoever's ever coming in is not going to. You don't need an AR-15. It's harder to aim. It's harder to use. And in fact, you don't need 30 rounds to protect yourself. Buy a shotgun. Buy a shotgun.
And
All right, little video on how this works, how to mix this stuff. It's actually mixed in, it's a reconstituted thing, so it's a powder in one vial or one bottle, and a bag of 200 mLs of saline in the other. You mix them, reconstitute it, shake it up for 60 seconds, and then it ends up being a 200 ml drip over 15 minutes. So you got to get the entire contents of the bottle into the patient in 15 minutes. So because I've been so downright evil with this of late, I can't do it. So if we had to do that kind of work. I guess I can't. There we go. There we go. So we had to do 200. It won't work. I guess I can only draw on certain things. Oh, whatever. We'll watch a stupid video. Oh, did I shut it down all the way? Oh, man. I didn't mean to do that.
Late at night where I fall asleep in the chair. I'm not watching it. Yes, I do.
Hi, I'm Dale Rollison. I'm here to talk to you today about the Sino kits and the Rad 57s that we carry on our QRBs. Hanover Fire and EMS recently released to the field staff,
My bad.
which will assist us in treating our patients who have become exposed to toxic twins involved in house fire. Those toxic twins are referred to as carbon monoxide and hydrogen cyanide. Patients who are exposed to those gases can have signs and symptoms that are serious for tissue failing and brain injury, as well as potentially death. So we come back to the patient that has been exposed to the toxic twins.
And literally, it comes in a box. Literally, it's a big white box like this that usually you keep in a separate container that's away from all the other stuff, and you pack it in foam and lock it up with 8 different, zip ties so it doesn't come apart. But it comes in a box, and you actually take the box apart.
They've been brought to you as the EMS care providers, showing serious signs of altered mental status, dizziness, nausea, whatever it may be. The BLS providers that may be in contact with this patient originally need to provide the foundations. 1, start immediate evaluation of the SpCO2. Levels that show greater than 20%, document that. Pass that along to the ALS provider. Now the ALS provider is triggered in understanding what is the next treatment regimen that may be necessary for this patient. In the development of the Sign No Kit program, we assured everybody that we would try to put it all in one safe kit, that they could have access to all the tools that they needed in order to deploy it appropriately. Inside the Sign No Kit, again, we have the 2 vials, the blood draw tubing, the administration tubing, as well as the dual puncture system for the 100 milliliters normal saline bags that you'll need in order to make this work for you. All this kit is a development of 2.5 per vial grams of high-dose vitamin B, giving you a total amount of 5 grams. Each vial should be administered over 7.5 minutes, which traditionally is going to, with this tubing, that's a 20-drop set, vented system should be wide open over 7 minutes, and you should be able to administer the entire amount of 2.5 grams. After that initial amount, you should, again, start to see some significant clinical changes in your patient's presentation. The BLS partners that will be assisting you need to make sure that they establish good airway, breathing, and circulation foundation and have those in place for you. Once you arrive, 2 large bore IVs will be the most appropriate immediate access. One of those IV ports is where you will need to do your blood draw. Again, get this primary before you give the medication so the hospital can run tests and see what the hydrogen cyanide levels were on the patient before you gave the antidote. Once that's established, then we'll take the 100 cc bag of saline, the 2-way puncture system for the 100 cc saline, and the vial. Introduce the saline into the vial of the cyanode kit, and then slightly shake and turn or spin the vial so that you can get the medication constituted to the saline. Once that's done, then you would use the administration tubing, puncture the vial again, and then run that 7.5 minutes over time, wide open, into one of the large bore IVs. The other large bore IV that you're able to establish, you can use normal saline with, or you can utilize that as just a saline lock and have that access there and available if conditions should change. Right now, the only contraindication to the administration of the cyanide kit is a patient that is in cardiac arrest. Other than that, you can administer this to a patient that presents with the clinical signs and symptoms of an exposure to the toxic twins and transport them to the most appropriate facility. Today, Memorial Regional Medical Center has the lab available to do the primary testing as well as MCV, but the secondary treatment regimens that this patient may require in order to be 100% successful is a hyperbaric chamber, so MCV would be your hospital of choice.
Blah, blah, blah. All right. It's not kind of what I'd hoped. Some of the things, I literally wanted you to see the contents because we don't have any to play with. It's not something that we have, and even the expired stuff, I don't think we've ever gotten our hands on one to even play with. But a couple of the things that he had mentioned in here that's important, and kind of looking at, and I unfortunately shut everything down that I had pulled up during the break, so bear with me. Let me go to page 54. These are our own local protocols, which I won't often refer to, but it's actually done pretty well to kind of give you a there we go. Now, he just said in that, if you were listening, that the only contraindication is cardiac arrest. That is not a contraindication as far as our region is concerned, nor have I ever heard that to be a contraindication ever for the administration of this drug. Specifically, if they're in cardiac respiratory arrest from what you suspect to be a toxic exposure from smoke or cyanide poisoning of some degree, or they're symptomatic, i.e. the systolic BP below 80, all right, with no explicable other etiologies. It's not a trauma patient, he's not bleeding out, it's not a, little old lady who, overdosed on their beta blockers or whatever. You need, and soot around the face, in a fire, in an enclosed space, pulled out by firefighters perhaps, and you're resuscitating. There are two versions of that. He's using the 2.5 gram variety, where we here, and we've kind of all trended across the country to all use the 5 gram variety. 5 grams that you mix in 200 mLs and give over 15 minutes. So, let's see if I can get my pen to work. I'm having issues. I can't draw on things, which is causing me not working. It's very upsetting. No. Oh well. Well, that works, but I am not doing it by the mouse because my handwriting is bad enough without the mouse. I have to use the pen or it won't work. So, but the question simply is going to be, if you have to give 200 mLs over 15 minutes with a 15 drop set, what's your drip rate? Over 15 minutes with a 15 drop per ml set. 200 drops a minute, right. So if you're using a 10 drop set, what would it be? Less or more than less drops per minute? It's 133 to be exact. So, and that's what comes in the kit, is a 10 drop set. So you're actually reconstituting a 200 ml substance containing 5 grams of hydroxycobalamin, which is vitamin B12 on steroids, and you're going to hang it and mix it either through a second IV or through a piggybacked IV, and hang it over 15 minutes. So most places have nice little cards that, because in the throes of this kind of thing, you don't want to forget or screw something up, especially with a medication that there's really no room for error in administering. It comes prepackaged with its own little bottle of saline and its own little bottle of powder, and there's this double-ended thing, and you double-ended spike, and you spike the saline and spike the bag, and you actually drip the saline into the bottle with the powder in it, mix it up, turn it upside down, spike it with a drip set, and then hang it. The only different here is the pediatric dose is 15 milligrams per kilogram over 15 minutes. All right, but this is for anybody that's cardiac respiratory arrest, seizing or systolic BP below 80 with signs of hyperperfusion after exposure to smoke in an enclosed space. All right, it's pretty simple. They want you, if you have it, they want you to use it. And the one thing that they had said, and the blood tubes come in the kit. They want you to draw bloods. We have in this area, in this general area, I don't know what they're doing up north or out west, but we have stopped drawing pre-hospital bloods for a logistical reason that will resolve, I suspect, at some point. Because, quite frankly, we're drawing bloods, then we're filling people with water, and then they get to the hospital and their bloods are altered, or we're giving medication. So the best bloods to get are bloods that we take prior to us doing something. The problem was a HIPAA compliant ability to label them in a manner that made the nurses happy and the hospitals happy. And in absence of that, they said, you'll just stop. I know a lot of the hospitals in the area were kind of upset that we stopped doing that, but understood that we take our orders from our bosses, and our bosses said, stop doing it. So, but this is one of the occasions where we do indeed still draw blood. So before you administer this stuff, it comes with 2 big gray tops. Draw your 2 big gray tops and make sure that you draw before, because they want to send it out and make sure that the cyanide level is commensurate with the signs and symptoms that you're observing on the scene. So, all right. Other than that, it's just a simple, volume infusion over time. And like I've said before in lab, when we mix, while it's 5 grams over 20 minutes, or 5 grams over 15 minutes, but when we mix the 5 grams at 200 mLs, it stops being 5 grams and starts being 200 mLs. And we're just infusing 200 mLs over 15 minutes. The 10 drop set equals 133.3333333333. So you have to work really hard to get that 0.33333 drip. So that's that. All right, now on, and that's cyanide. And the one important thing to bring home is one of the misconceptions is cyanide is not a weapon of mass destruction. While it is, certainly it is, it is also not something that you can get from overdosing on apple seeds, which there is a very finite amount of cyanide in apple seeds. And if you ate a box of them, certainly you could probably metabolize something. Like the video said, yes, if you're a victim of cyanide poisoning, You do have an almondy, like a burnt almond odor on your breath, kind of like the cruddy burnt Fruit Loop odor in diabetic ketoacidosis, or smelling like a bar if you've overdosed on alcohol and your body's trying to breathe out alcohol components. In your body tries to use water vapor in your alveoli to work out toxins, whether it be sugar, cyanide, alcohol, you name it. So all these things are true, but one of the things that we don't often consider is that cyanide's present in almost all residential fires. Any plastic that burns gives off cyanide. Anything that's made with polyvinyl chloride, PVC. And PVC's in just about everything these days. So, anybody that's overcome by smoke gets treated for cyanide poisoning. If we have it. If we have the ability, great. You have the awareness, and it would be incumbent upon you that when you go forth and I kick you out of the nest and you go practice, that you familiarize yourself with your region and maybe who has these things, or if you have these things. So, or wherever it is you're going to land, maybe it has stuff, maybe it doesn't. And this is one of the kind of things, this is a new technology. The hospitals aren't quite on board. Some of the old guard in different agencies that are maybe holding agencies hostage because that's the way we've always done it. It doesn't always work. And this is new technology that is working. So, there, end of sermon. I have to find my PowerPoint for carbon monoxide, which carbon monoxide is actually far more relevant than any of us realize. And the more we look for it, the better off we'll be. Now, I had mentioned this before, that we're lucky in the fact that technology is our friend, and unfortunately, while technology costs money, the new generation of cardiac monitors all kind of has covert CO monitoring or carbon monoxide oximetry built in. And the way it works is, we all know basically how a pulse oximetry works. It actually takes a beam of light and shines the beam of light into your nail bed and kind of looks for bound hemoglobin. All right, and the limitation, and it's one beam of light, one frequency, beam that's directed through a filter looking for something very specific, and it's only the very broad finding of bound hemoglobin. It doesn't care what it's bound to, but it needs to be bound to something. And that's why, simple pulse oximetry can give you a false high if you're in CO poisoning or, any other substances that may bind hemoglobin with greater affinity or equal affinity than oxygen would. All right. CO and cyanide are one of those things. The new technology that's coming out with CO oximeters and even CO and CN oximeters, because you can have an oximetry machine or a probe that actually gives off the light that's specific for CN bound hemoglobin. And there's also a beam of light that's filters through that's specific for carbon monoxide bound hemoglobin. That's a bit older technology. That came out by a company called Massimo about 10 years ago or so. And they developed a little device called a RAD-57. And that was a very specific CO oximeter, pulse ox or O2 CO oximeter together. They couldn't be used at the same time. They had to be switched. So if you had the handheld device, which it was a long handheld box with the wire and the finger probe, and you said, look for oxygen, and it would give you a reading of 100. And then it would ask you to look for CO, and you had to switch it, and you couldn't read oxygen while you were reading CO. So you had to completely switch the machine from one mode to another to look for the different things. Now, with the new technology, it's looking for CO at the same time as looking for oxygen. All right. For my specific machines that we're using, the LifePak 15, the pulse ox probe itself is $800 because it's given off like 13 different wavelengths of light looking for different things. It's looking for your pulse oximetry in a global bound hemoglobin state. It's looking for carboxyhemoglobin, which is CO bound to hemoglobin, or hemoglobin bound to CO. And it's also looking for methemoglobin, which is CO bound to cyanide, or certain forms of cyanide, more commonly found. And there's weapons grade cyanide and stuff produced in a lab that I'm sure we can't find. But the typical, garden variety plastic burning brand of cyanide is something that we can detect now in the field. And like I said, the guts of my machine are expensive, and the probe itself is $800. So, be very careful when you get your scissors out and you're cutting, or when the probe falls off and you roll over it with the wheel of the stretcher. Yeah. So, but carbon monoxide is a big deal, right? So, yeah, Mike doesn't look for, he's got to do his disclosure. I stole this from him. I unabashedly stole this from Mike McAvoy, who was my friend, and gave me permission to do this. So, he is, and I'm only doing this because he couldn't come. And I asked him to, and he's out of the country at the moment. So all right. We know that carbon monoxide is colorless, odorless, tasteless, and non-irritating. It exists in nature and all over the place, and we'll never know it other than for the fact that it's too late. All right. It's got all this crap, which we don't really care about. And here's... Oh, whoops. But I don't have that up there. Stand by. Yeah, something went weird.
No, I didn't know what they were seeing.
I can't see. Yeah. Hold on. Stand by. Malta, unmute yourself.
Yes, sir.
Are you looking at my presentation, or are you looking at some dude standing there?
We have your dude with a mannequin. Well, we have your presentation, and on the other screen we have the video still there. We can't see you.
With a mannequin.
You can't see me.
Correct.
Well, all right. Well, I'm not that guy with the mannequin, so.
We figured. Well, then I guess we're not looking at you.
I was pretty sure that the bald head gave it away.
I don't know. All right, well, as long as you can see the presentation, you can hear me, then we're good. I'm not going to worry about it. The guy with the mannequin is not me. So, all right. We don't care about much of this stuff. All right, what we do care about, though, is sources of carbon monoxide. All right, and it comes off in the incomplete combustion of any carbon-based material will produce carbon monoxide. Automobiles, and most of us are all aware of, sucking on an exhaust pipe is a rather effective way to expose yourself to carbon monoxide. Gas heaters and furnaces, small gas engines, lawnmower engines, generators, if they're not left outside in an enclosed space, space heaters, furnaces and gas hot water tanks that are not burning properly, specifically, yeah.
Now it's switched. Now we can see you, and we can't see the presentation.
All right, I can do this. What about now?
Now we can see it.
Good.
All right. See, that's Roger fixing it in the background, and all is well again. Okay. All right, and all these things, and we're mostly aware of all these things. However, it's not something that we can often appreciate, as most of these things occur in the background. Specifically people that are inside their homes in the colder months and have, inefficient heating systems and the like that are exposing them over time to lower levels of carbon monoxide that they will, ultimately succumb from prolonged exposure. All right, and cigarette smoke, and that becomes relevant later on down the line because most of you smokers, if I put the probe on your finger, you probably register 6-7%. All right, which anything greater than 5, we kind of raise an eyebrow at, except if you're a smoker. So, all right, parts per million. This is all. We're not looking at when we look at an oximeter, it's a percent, not a parts per million. All right, but just to kind of see how this goes. I mean, obviously, automobile exhaust is very high. Smoking a cigarette higher than you'd think. In a smoky-filled room, regular old cruddy urban air has got a bunch of stuff in it. And anybody that's ever been to LA and come down from the Hollywood Hills and seen the smog lying over the city, it's pretty impressive. In a kind of make you freak out kind of way. All right. But volcanic gases. Those of us that live in either Hawaii or Oregon, Washington State, kind of worry about that. But the rest of us, we don't have any volcanic gases here in New York. So this is about my favorite thing, and this is the one thing that makes this whole presentation worthy. No, because it's actually it stands to reason. It puts in perspective the way things go. All right. Now, kind of looking at the different color coded here. All right, 5% carboxyhemoglobin. All right, so here's 5%. And if you're exposed to 5% over a period of time, and you can see, colors on one end, this is kind of symptomology on the other. All right, for the longer time, you've got a very small window, and your parts per million, kind of goes out. You can about 5% for very short periods of time is not harmful. Anything over like 2 hours or so, 3 hours, you begin to worry. Now, 10%. All right, and you start looking at thresholds. The longer, and if you're at, 10% for 0 minutes, there's not much here. But again, over longer stretches of time, your exposure risk becomes much greater. All right, the kind of the highlighted areas here, and if you look at something, here, slight headache, at 15%. So, if you're at 15% at an 1,800 parts per million environment, you're going to have that within, 5 minutes. However, if you're in a 200 or a 100 parts per million environment, you're going to have that, in a little bit over 2 hours. And it's going to sustain and build up and build up and build up. So it just kind of shows you that it's cumulative, and we're not really able to rid ourselves from it. And a lot of the times when we go into these houses where the CO alarms are going off, it's 10, 15, 20%. The fire departments get readings where we look at oximetry from a percentage. They're looking at readings from a parts per million standpoint. And we see typically, and you firemen can certainly chime in here, but 6, 7, 800 on your meters is high. And it's like, oh, all right, that's high. It's real high. Open the windows, get everybody out, and you look for, symptomology, from that point, or people being symptomatic. So, looking at an environment where you're at 600 parts per million, it's in winter, and it's been 10 degrees below zero, and it's an old gas burner, furnace. Being exposed to that environment for, we look at the red where it's, brain damage and death, 60 minutes, you could die. 80 minutes, certainly. So somewhere in here. So just a neat graph of how this is all done, and it gives you some perspective. If you're at 400 parts per million, which is a exhaust-filled garage, you're dead in 2 hours. It puts it in perspective. So, when people present with, nausea, vomiting, lethargy, all these things, kind of looking here, Well, they've been inside their house for 6, 7, 8 hours before they haven't opened a window, haven't opened a door, and in 4 hours they're looking at fatal amounts. Certainly. So kind of nice, kind of puts it in perspective there. All right, probably one of my favorite things. A lot of this stuff is just kind of things where case studies and how these things go. 52-year-old male, guy in Salt Lake City, fell home. Boiler discovered, and the readings were only 130. Going back, 130 is very low, but again, over time, it only goes up to 240 minutes, which is 6 hours or 4 hours. But you can see how over time everything kind of bands together. So several days of being inside, it builds up and builds up and builds up, and the less hemoglobin we have available, the less oxygen we have, or the more bound hemoglobin to cyanide, the less oxygen carrying ability we have, and ultimately, you can succumb from that. So pretty profound. 50,000 ER visits annually from what we know to be carbon monoxide poisoning. Now, this is only because of recent developments in the technology. How many, for those of us that are working EMTs, how many benign nausea, vomiting, headache, flu-like symptoms have we transported in our careers? A whole bunch. So, something that we should always consider. That's why I said the technology is nice now, because it covertly monitors CO in the background, and someone where you maybe wouldn't consider CO right off because you're still going through the differential of of an assessment and sample history and all these other things, and you put the oximeter on the patient's finger, and all of a sudden the big red light flashes on the screen and tells you that their SPCO is 17. Okay, well, I guess we figured it out now, haven't we? And then you start looking at people in the house that don't have symptoms. They're, and looking at them. So we're not going to go. This is, a lot of information on here, and for those of you that are interested, we'll keep it on. I'll put it on Blackboard tonight. But again, having Mike here would have been awesome, but unfortunately couldn't make it happen. All right, there's this guy. He's awesome. Increased accidental CO deaths. Patients over 65, male, intoxicated by ethanol or ethyl alcohol. Accidental deaths peak in winter. Heating system, closed windows. All right, and related to loss of utilities. As I said, there was in a community not far from me. A fellow was a retired professional firefighter, and it was during the post-flood blackouts that we had, or power loss that we had, or one of the hurricane when Irene rolled through, and portions of the community were out for 3, 4, 5 days. People were using generators in all manner of ways. And this fella decided that it would be too inconvenient to go outside and refill it with gasoline. So he put it in his garage. His garage was attached to the house. Well, the house filled with CO, and he was dead the next morning. So, again, retired professional firefighter, you think you'd know better. So, but, happens a lot. Again, something that we hadn't seen. Something that I hadn't ever considered, just on an aside from that, is we had an area of our town that was decimated by the floods post-Irene. And we got everybody out, the water receded, and National Grid came through, and they, were stunned that we didn't have the hazmat team, all ready to go. I was like, well, where's the hazmat? It's a public health emergency, where's the hazmat? He goes, fellas, every pilot light in every basement in this area is now belching out methane. And we hadn't in every basement, and since methane's heavier than air, every basement now has got to be ventilated because every basement now is filled with natural gas. never even considered that because we're not used to dealing with floods, So, and we had to go through and go in there, and guys with SCBA to go downstairs and open up windows to try to ventilate and turn off the gas services to these places, and don't light a match. So, just something else to consider from a standpoint. All right, and more case studies, but more importantly, what do we do? All right, to take care of these folks. I'm going to go back to our protocols here. Symptomatic patients. All right, if the CO alarm goes off, which most of them don't, or the batteries don't work, or they go off in air because they're a lot more fickle than smoke alarms are. All right. But we try to figure out who the symptomatic patients are. Headache, nausea, vomiting, lethargy, inability to eat or drink, all those kind of benign flu-like symptoms, all right, or anybody that presents greater than 30% on the CO oximeter, which is high, all right, and they go right to the hyperbaric chamber, all right. If we are greater than 15% in the street, we'll treat them for a bit, we'll get them out of the environment. The treatment for CO poisoning is oxygen. And while hemoglobin does bind to CO a lot faster than it'll bind to oxygen, the antidote for CO poisoning is indeed oxygen, because if you saturate an area with as much oxygen as we can, it'll encourage competitive binding to hemoglobin by oxygen. And hopefully, within 20, 30, 40 minutes, washing out whatever CO we have and bringing people's oximetry of CO down and their pulse ox up a bit. Their actual not their pulse ox, but their hemoglobin bound to oxygen. All right. So, 15% is that kind of cutoff. Anybody below 15%, figure out what their underlying history is, if they're smokers, if they work on vehicles a lot, they're in an environment where they could be potentially exposed or perpetually exposed to CO. But anybody over 15%, receive oxygen for 30 minutes, then reassess them. All right, unless they're symptomatic with a reading greater than 15%, then they have to go to the hospital. And according to our protocols here, we talk to physicians on the phone, and we figure out where the patients need to go. If their CO saturation reading is over 30%, all right, or significant altered mental status, pregnant patients, immunosuppressed, or some other issues, or anybody that's got a complicated history and a difficult underlying, maybe heavily medicated, the elderly, etc., that wouldn't bounce back as easily. A hyperbaric chamber will benefit them, and they'll take them down an atmosphere or two. And hyperbaric chamber is just that. It forces O2 into the cells. It actually will allow oxygen to push off CO. All right, where in a normal environment, we just encourage them, or the presence of high flow oxygen or high concentration oxygen in the blood encourages the competitive binding by oxygen to hemoglobin. In a hyperbaric environment, it actually forces it. All right, and with several hyperbaric treatments, usually these folks can be turned around. However, it's one of the things where med control should be considered. And for us here in this area, and most areas of our viewing area, if you will, with the exception maybe of those areas that are maybe within an hour or so of Syracuse, because that's where the hyperbaric chamber is, upstate Med in Syracuse, Boston, or down in New York City. All right. There are smaller chambers for wounds that won't heal and other smaller hyperbaric issues, but the big ones that people can go in, lie in supine, and be brought down to several atmospheres exist in the big hospitals, and there is not one in Albany. All right, so that would be a helicopter transport. So, these are things, and again, if you see patients, and there are, and you hear about them, there are several a year. Usually, actually, this year has been a relatively quiet year. Usually, my community is good for one MCI a year. An MCI being, 4 or 5 patients from one house that are all sick. Or, you get the elderly couple in a closed house. That was a couple years ago. That was a flight job to Syracuse. Both of them were very, very sick. They both survived. But, I think the CO levels inside the house were around 700-800 parts per million. I mean, they were real sick. They're real sick. So you see this, but again, it's the benign ones. It's the low level nausea, vomiting, just general flu-like symptoms, and the whole house is sick, and you don't think about it until now we have the technology to do it. So, the protocol here talks about the RAD-57. That is any CO oximeter, because there are several, and each of the companies now has their own technology. All right, so don't just go by that. All right. Like I said, heavy smokers have a baseline SpCO up to 10%. All right, watch for the sensor. Watch for people that aren't perfusing well either. All right, it isn't really a good adequate, just like a pulse ox. Anybody that's got a cold or a non-perfused extremity, pulse ox is unreliable. Another thing with just a little trick of the trade that I learned when we got our new machines is they actually now come with a boot for the probe, and you're supposed to put this black blind over the oximeter because it's very sensitive to light, and it's supposed to be read in the dark or in as close to pitch black environment as you can. So if you're going to read people, cover it with a towel, use the boot, something that's going to take any ambient light possibility away from that probe, because it won't read properly. You get a false reading. All right, so one of the things they say, don't put the thumb, all right, or the 5th digit, which is the pinky. The thumb is actually the first digit. 1, 2, 3, 4, 5. Use a big finger. Use one of the big fingers. That's about it. But one of the things, in your book will bring up some good points too, but the treatment for carbon monoxide exposure is oxygen, period. There's no drugs involved, there's no anything fancy. It's awareness, recognition, rapid treatment, and oxygen. Oxygen. All right? And these are people that will perhaps be saturating in the normal ranges. The cherry red skin doesn't exist, for a very short period of time. And, they had touched upon that in that video. Cherry red skin is, kind of that drug being, administered and you pee red for a week and a half and all these things. But what's polycythemia? Due to hypoxia, what happens is over time, your body produces a lot of red blood cells because you can't breathe, and there's a lot of unhappy hemoglobin running around. So you're thinking, if I make more hemoglobin, I'll just have more bound. But so you have an abundance of red blood cells. And what you see in that cherry red skin color is kind of the opposite effect of polycythemia. What you have is bound hemoglobin that's bound to CO that's in the venous system. And as we know, our venous blood is darker red. Right? There should be unbound hemoglobin and should have a lot of carbon dioxide either attached to hemoglobin or bound and dissolved in our plasma that we're bringing back to our lungs to off-gas with our respiration. And because there's no use for CO anywhere, the hemoglobin stays bound to CO, works its way through the capillary circulation and then into the venous circulation, and we have brighter red blood in our venous circulation, which can make us, in certain respects, appear that cherry red. That's like near fatal. And what happens is, for the minute before you die, you're bright red, and then you die, and then everything turns purple anyway. Once in a blue moon, you'll see somebody that's dead from a CO exposure that still exhibits bright red blotches of kind of coagulated bound blood in spots where it hadn't worked its way out yet. But for the most part, pale, cruddy, shocky, nasty, flu-like, barfing, headache. That's how they present. Every benign system possible. Yes?
Yeah, but the red blotchiness, that's like way far gone.
Yeah. Yeah, you're sick. Yeah.
Like,
real.
Completely irreversible.
Yes. So, all right. So, treatment for CO, oxygen. Treatment for CN, B12, which is also called hydroxycobalamin, which is the new drug. It's marketed under the trade name Cyanokit, and the dose here in our general area and pretty much nationwide is 5 grams over 15 minutes to be administered as close to possible at the time of exposure as we can. And what is the side effects? Red skin, red urine, screws up your blood labs for a while, your ABGs and other things for a while. And what are the contraindications? None in the emergency setting, unless you're known to be allergic to any of the components.
Vitamin B.
B12. Thiamine, yeah. Mega doses of thiamine. So that's that. And aside from that, the 2-PAM chloride and the other things in that video are kind of an older technology, and we're all kind of older pharmacology, and we're all evolving to hydroxycobalamin. So, what? All right. That's all I want to do. 8 o'clock. Now, before you all go scurrying away, this will give you time, for those of you that haven't, get your drug stuff done for tomorrow night, because we're going to start. We'll talk about all the drugs that I've given you thus far, and begin cardiology, and then we'll have a bit more drugs that I would like to introduce and say, by the time we get done with rhythms and we start talking about arrhythmia treatment, you'll be up to speed with the drugs used and just familiar with them as we move forward. So stay out of the snow, drive careful. Now, tomorrow night, I have no insight as to what we're going to do. If Hudson Valley closes, I suspect the entire day is closed. However, if night class is still going, we're still here. I don't know if they differentiate. Day class is closed, night class is on. I will, watch your group texts during the day. All right, but if Hudson Valley's closed and closed for the day, unless they specifically say night class is on, then we're closed. That's why I'm not planning anything massive, and whatever I do have, I can certainly do over Blackboard and some other little things over the weekend. So keep your eye on what's going on. But hopefully they can get the roads cleared and we can be here tomorrow night. But if not, they're saying it's going to go all night and then it's going to start again tomorrow, intermittent during the day. So who knows? I just want to be prepared so I don't get, a bunch of things. So watch the things. If Hudson Valley's closed, then we're not here.